Is now starting. All attendees are in listen-only mode.
Welcome, everyone. Have a happy Tuesday evening to you, 8 o'clock here in Florida. Rich, how you doing this evening?
Thank you. I'm doing well. It's
Great.
good to be back on again. We enjoy doing these for you guys, bringing them to you about once a month. And tonight we're going to talk about out-of-network billing for dental sleep devices. And guys, there's a lot of stuff to go through tonight, isn't there?
There is, and I know this isn't our first rodeo, not the first time we've ever talked about billing in a webinar, but you know what? It changes every time we talk about it because medical billing
That's
is
true.
one of those things that is always changing. If we have time, we'll talk about some real hot off the presses changes with Medicare at the end. We're going to focus on out-of-network medical billing. I think that's one of the most challenging for dentists, and most dentists are out-of-network for medical. And we will focus on that, and it will be different than the last time that maybe you all heard us talk about billing, in particular out-of-network billing. We talk about the 4 pillars of success for dental sleep. You need to screen, test, treat, and bill your patients. If you have a system in place for all those and team members who are trained, dental sleep can be, I say one of, but I honestly believe it's the most enjoyable service you can provide in your dental practices. Dental Sleep Solutions, DS3 will help you do that. Today we'll talk about insurance. Do your team members ever felt like this is what they're doing all day long for insurance and everything else, Rich?
Yeah. You know, when I do a consult, guy, people always, right towards the end, they go, well, what is this going to cost? What's my insurance cover? And I say, insurance. Oh, don't say that word. It makes my blood pressure go up. So, Catherine's going to come in and talk to you about it. So, I think it makes everybody's blood pressure go up a little bit. The doctor, the patient, we all, sometimes you wonder who's winning in this. We all feel like we're paying a lot for our insurance and deductibles and all this other stuff. So we know that's what people ask, don't they? And we know our staff, the more educated, the more knowledgeable our staff is, the less stressed they will be, and the more, I think the more satisfaction we get out of this too, which is kind of a tangential point, but it's very true.
Yeah, and medical billing is not the same as dental billing. We'll talk about that briefly today because I know a lot of you are kind of new to medical billing altogether. But we want to emphasize that we're trained to do certain things. Most things on the screen here shouldn't make you nervous as a dentist. Root canals, crowns, implants, diagnostic, injections, all these things, although to the general public may scare them half to death, to us we're comfortable doing them. But if we told you had to fly your own plane because the pilot was sick, or defend yourself if you went to court, or do your own taxes, build your own house, it may stress you more. And it's not that you're not capable of learning how to do that, but is it worth the time and energy when there are trained professionals on how to do it? And we will teach you how to do out-of-network billing today. But that's just really the philosophy and kind of the flow. The actual billing and the tracking down the money, we highly, highly recommend whether you use 4-pillar billing, Pristine billing, Go-Go billing, or some of the billing companies that we'd recommend and work with through DS3. Use a third-party biller, and you can do what you what you are trained to do, and that's and like to do, and that's do the dentistry. So we really emphasize that to a large extent. So use a third-party biller, and if you don't know of one, we have our team members on today from 4-pillar billing. They're an arm of DS3, and so we'll be answering questions as you go through. So if you have questions, put them in the question box, and we will, our team of experts will be answering those as we go. And then when we're finished tonight, Rich and I will personally answer any ones that they didn't get to. So there's no reason why you should have to recreate the wheel. So Rich and I don't practice together. He practices in Texas and I practice in Florida, and we have different philosophies. But as I was putting this together and talking to Rich about it, I said, we did this webinar maybe a year ago, maybe not even a year ago, and I said, some things are different in my practice. They're different than when I talked about this maybe 6 months ago to one of our in-person courses. And 4 things is that I've changed in my practice, and I think Rich does these as well. Well, not as much as me on the first item is I used to always accept assignment of benefits on these insurance patients, and I'll explain why I've changed that a little bit. I used to not have options. I used to not have a provisional plan, and I used to always go for gap coverage just kind of right out of the chute. And this is something, Rich, that I'm doing a little bit different. I know you do it a little differently than I do, but I'd like to start with talking about what's different. And in my practices, we have 3 practices, one in Sarasota, Tampa, and Bradenton, Florida, where we just do dental sleep. And these are some changes that I've made in my practice. So let me start with the first one. Rich, you always explain what does this do when you either check the button in DS3 or there's a line, I forget which line it is on the form because I never filled out the form, accept or don't accept assignment of benefits. What does that mean?
Yeah, I think it's box 27, if I'm right.
You're
I
right.
know Lisa from Four Pillars on here. She could put that in the questions maybe to make sure we're right. But I always remember that as if you don't accept assignment, you don't get the check. That's how I always remember it. So if you don't accept assignment, and we'll talk about what that means. That actually means you can bill more, and that means you can balance bill the patient, and you can do some other things and actually allow more. And that's part of what we're here to learn about. But that's how I remember that.
That's exactly right. So if you don't check the assignment of benefits, the check goes to the patient. So if you trust your patient and the patient's going to pay you that money, if that money is ultimately yours, then by not checking accept assignment of benefits, you are basically not obligating yourself to be a provider for that insurance company. So even for commercial insurance, if I accept assignment of benefits, then by doing that, it's making me as a dentist more liable to adhere to the rules and regulations that particular insurance company's put forth for me to allow that check to come to me. So one thing we changed, in most cases, we don't do that. Now we ask for that money from our patients, but let the check go to the patient, let them deposit it, let them write me a check for whatever amount they owe me. And as long as the patient doesn't keep the money and run off to the Bahamas, I have now taken some of the responsibility of audits away and put myself at less liable if, in fact, I need to write off some accounts or something that's along that line. So, and here in Florida, we must have fairly honest people, or my team's pretty good at discussing this with them. I'm not having a ton of time. I'm not having a hard time really getting that check, getting the monies from the patient. So this may not work in all areas, but in my areas, we used to always accept it. And now, most of the time, we're not, even though some of that money that's going to the patient is really ultimately going to go back to us, and I'll explain how in just a little bit. So if we talk about Medicare in a little bit, that has a whole different meaning too. If we have time, we may address that. If we don't, understand most of what we're talking about this evening really is commercial insurance.
But let me reiterate there, Guy, that you have to make it absolutely perfectly clear to your patient that the check is going to them, but they don't get to keep it. We make an initial 3 different places on our financial arrangement. And occasionally, like you said, you get somebody that goes, oh, I thought that was my money. No, here's a copy of what you signed. This is where you initialed that said you understand it. So, and we do that a lot too, Guy, and there's only been a couple of instances out of hundreds where we had trouble getting that.
And you're not going to get the money sometimes. And I think part of what we're going to talk about in a little while is if you are going to do that and take some risk, you have to build that into your fee, because you have to accept that you're going to not get the money sometimes. And sometimes the money's not going to be as much from the insurance company as you predicted, because we don't know for sure how much they're going to pay. So you've got to be tolerant to a little bit of up and down, and you got to cushion yourself by getting a little more money with the expectation that sometimes you're going to get less money than you thought, and sometimes you're going to get not the money, the patient's not going to give it to you. I see we're having some questions coming in, Rich. Just to reiterate, we'll be answering those as we go. Our DS3 team and 4-pillar billing team are going to answer those, and we'll get to all of them, so keep them coming. That's fantastic. The other thing I changed, Rich, and I think we both did this, but I did it a little differently. So someone came in and we gave them their fee after insurance, or including insurance, however you want to say it. We'll get to that in a few minutes. But they would say, oh, I just can't afford that, Doc. What else can you do? I don't know. It just dawned on me. Actually, I have a new partner, and he and I were talking about this. And in my dental office, I didn't just walk out of the room, walk back, and say, well, we'll do it for less. I had a plan A, implants, bridges, and I had a plan B, partials and other something else. There was always 2 options based on affordability, but they were both good options and options I felt good about. So kind of what we do now in my office is we look at what we hope to get out of the insurance, and then we look at what we least would think we're going to get out of the insurance. And what we hope to get out of the insurance, we'll tell them that, and that's what plan A is, and we include whatever in that. And we have a plan B if we, on the low end, what we expect to get out of the insurance. We're going to show you how you can estimate that here in just a few minutes. So that's a little different than what I used to do before. I would just kind of walk out of the room and if they couldn't afford it, try to somehow make it affordable. And we even, anything on that, Rich, do you do something similar to that now, or anything to add?
No, that sounds reasonable so far.
Yeah, and we actually have 3 plans. But this one, I think, what'd you say, Rich? You keep this one in your back pocket?
I like to say that way, Guy. It's like, before I let them walk out the door, this is our kind of provisional plan, so if A doesn't work and B doesn't work, then we pull out of our back pocket this to try to, I think it's fair, Guy, because I go to work because I want to treat people. I don't go to work to turn people away because they can't afford it, but I also have all this building and all this staff and all these people to pay and all that other stuff. So I think everybody understands that. So, you just can't reiterate enough that patients really want to know what their responsibility is. And I think, Guy, you put together a great PowerPoint here to try to get that through, because what makes that hard is insurance companies won't tell us what they're going to allow, and they won't tell us exactly what they're going to pay. And even when they tell us that, sometimes they don't always do that. Right. So that's hard for us as dentists to accept, because everything we do is so structured and, organized, and right. And we don't have that problem. But
yeah, and I presented this. We had our study club meeting. We have a premier study club meeting for all of our members, a free meeting here in Florida once a year. We just had that Friday, just a few days ago. And one of the things we talked about at our study club meeting is patient objections. And we made a list at the beginning of the time we were going to talk about it. Give me all your objections. Why do patients not want to do treatment? You know what 2 of the top ones were? Everyone's going to know the first one is money. Maybe money's a perception problem more than an objection, but we talked about that. And number 2 is, will this work? I don't mind paying this money, but I don't want to pay this money if it's not going to solve my problem. And you cannot promise them that it's going to, unless you use a matrix system, and even then you can't 100% promise them. So what we do is this one out of our back pocket. If they can't afford, we can't work out option A or B, and they say, I'd like to try something, I don't want to spend as much money, then we have the option of doing what we would call intermediate device, provisional device. You can use whatever words you want to in there. We make them a temporary device of some sort. I've been using the MyTap. I like it quite well from Airway Management. It's just a good device, easy to adjust. We make that in the office. We give them that option. You can do it for however much you want, a few $100s. You have to set your own fee on that. But then we have them back and see how they're doing with it. We may even, if they already had a sleep test, give them a home sleep test or a pulse ox seminar, include that in our fee, make sure your fee is appropriate, and they can basically try this out. And it's an amount that they can usually afford, and if they like it and it works and they're happy, then they can move on to option A or B, and then we usually give them a discount that we've already discussed on option A or B. And so we essentially now have 3 options. So if it was dentistry, we've got the implants and ortho, and then we maybe have fixed bridge, and now we have partials or something. We really got it down. All these are better than doing nothing. All these were helping our patients. All these are getting us down the road of treating this patient. And I tell you, I just feel really good about these changes that we've made by having the options, and in particular to having this MyTap option, and as Rich says, in my back pocket. So those are some things that have changed, and we'll talk about how you use those in a moment. A little housekeeping. You will get CE for this. It'll go to your email. If you don't see it within the next couple of days, just check your spam folder. It'll be there. We will continue to answer your questions as we go along, so keep them coming. We have over 300, almost 400 people registered tonight, so we can't. We have to mute everyone's mics, but we will get to your questions. I promise you. Here's a good picture of Rich. I don't know so much about me, but we've been doing this a long time, right, Rich? I think most people know
long
that.
Time. I'm almost at 20 years now, Guy.
Yeah, we both. I went back and looked at that as I was doing the DS3 timeline, and my first patient, I saw her the other day, and we're going to be seeing her again in my office. I saw her out at a restaurant, and I hadn't seen her in a while. She hadn't come in for recalls, and it was almost 20 years ago that she walked into my office, and we did that first dental device. And I got a picture of her. I need to sneak into here one night and show of her updated picture from 20 years ago. But if you want to do this in your office, this is what we do. DS3 will help you succeed in dental sleep. We'll help you with education, coaching, software, and support. So anytime throughout the night, if you want more information on what we're talking about, we promise to give you the information, but it's going to be a lot of information. If you want more clarity, you want to just sit down and talk to someone that just does this every day, all day long, just type in consultation or consult, and one of our trainers will set up a time, clarify any of the slides we had tonight. We'll send you a copy of some of these flow sheets that I'm going to show you. So just type in consult if you just want more help with your dental device, with your dental sleep, rather, and we'll be happy to sit down at no cost to you. And Rich, this is coming up when, in a few weeks?
Yeah, a couple of weeks. Keith Thornton and I, Mark Bell is going to be joining us to talk about some marketing stuff, but we'll be in Dallas. And, Keith, he those of you that don't know Keith, he's got invented the tap, and he's going to talk a lot about how to, treat seriously ill people with a lot of comorbidities, and I'll talk about, billing and marketing. And, I have a very busy dental sleep practice in San Antonio, and we'll talk about how we get busy, how we stay busy, and how we treat people. So we only have a few spots left too, I think. So it's
a limited group. I think it's worth just to spend a time with you, Rich, from doing this long, and Keith Thornton. It's going to be a great course. I'm upset that I'll be teaching, I think, in Cleveland at that weekend. So hope it goes well. We do hands-on implementation courses all over the country. We have 3 coming up in the next 3 weeks. These are the most comprehensive how you do this in your practice courses in the country. They're 2 days long. They're just at $1,000 for you and a team member. It's a typical fee for this. You get a dental device and a sleep test on the dentist. I mean, that's worth the price of admission, and we offer discounts to anyone who attended tonight for $200. So for the less than the cost of a dental device and a sleep test, you can come spend a day. I'll be teaching these 3 coming up. I promise you'll leave with the knowledge that you need and the excitement to go do this in your practices. So if you want to save that $200 on courses, type course tonight. 1 or 2 other things here, and then we will promise to get to the subject at hand. The symposium is getting, we're well ahead. Last year was rapidly become the 2nd biggest dental sleep meeting in the country. Rich, it's a nice facility, wouldn't you say?
Yeah, pretty exciting. Great place to go in the middle of the winter for you guys from the north up there. And a really big list of speakers. And what we really concentrate on is how to do this in your practice, how to implement this. It's great to know about cardiac ejection fractions and all that other kind of stuff. I mean, I like that stuff too, but we really concentrate on how to help you do this and be a better practitioner, all of the speakers.
And there's a lot of speakers, 1 hour at a time. The rooms will sell out. They sold out last year, $250 a night, which is a great deal on the beach. And we'll be talking to you next month about the steps needed for treatment into dental sleep. So we'll go through everything from screening, testing, treating, device delivery, follow-up testing. So that'll be a good hour next month, November 6th, same time, 8 o'clock Eastern. The biggest thing that we see, Rich, and I'm going to try to go through these fairly quickly, but I don't think we want to rush the subject, but we do have to emphasize that when you do a dental device on a patient who has apnea, you're now doing a medical procedure. It's not a dental. You will not bill it for dental, and it's just entirely different. And I think medicine's different than dentistry. Rich, how long has it been since you've done a DO composite?
I refuse to answer that on the grounds that I might lose my dental license here in Texas.
Okay, it's been a while, but did you have to call a physician to get a diagnosis for that before you were allowed to do the DO composite?
Thank God, no, we did not. And I think that's a hard thing about dentists doing this, Guy. We're just hard to make that. It's almost like a whole paradigm shift in what's required and what you do and how you look at it.
Yeah, I mean, you didn't even have to have a diagnosis. In your charts, you probably ought to have distal decay, but you didn't have to have a code associated with that, and you made the diagnosis. In medicine, the physician has to make it, and then there has to be a code associated. In dentistry, you have to have an x-ray to determine if it's covered. In medicine, they don't ask for an x-ray They look at your chart notes. Your documentation is key. That's why something like DS3 is invaluable to making sure you've got everything covered. You know what, they don't pay you if they don't like what they see in dentistry. They look at that x-ray and the two-dimensional image, somehow they decide that you're not I don't know if that's ever happened to anybody but me, but that they can't see that buccal crack on the crown they need it for. They determine it from that, and they say, hey, we're not going to pay for this. And they tell you at the time you bill it or the time you send the pre-authorization. In medicine, they pay you, don't they? They don't come audit your x-rays first. They pay you and then they come back later, right?
Yeah, they can. And again, documentation, Guy, we could talk for 3 hours about, how you document things and do that. So I think everybody knows that, but it really is different. You're using a different form, you're doing that. And it comes back to what you said earlier, Guy. Unless you want to hire a full-time person in your office to do nothing but this, and even then, I'm not sure it's worth it. I would use a third-party biller, one of the ones that we recommend.
Absolutely, and we'll help you with the documentation you need. And in dentistry, we're used to being paid for everything, and if not, we got to tell the insurance companies that we didn't collect the difference between what they paid us and what the patient paid. In medicine, write-offs are normal. In dentistry, they're considered unethical if an insurance company allows $1,000 for the crown and they pay you $700. If we don't collect that $300 difference that the insurance didn't cover, they consider that unethical. I do this all the time, Rich, and I ask the people in the crowd, and they nod up for all dentists. Oh yeah. And then I say, what about medicine? Medicine says it's unethical if you don't waive that copay if they have a financial hardship. And I think that's the hard part to some degree for the ethics. And the reason being, we want to not let our patients die. I mean, you can die from sleep apnea. And I think it's different between teeth and most teeth thing and medical things. So in medicine, if a patient can't afford something, you take the insurance money and write off the balances that they can't afford. And that's commonplace and ethical in medicine. And we could talk about it all day long, but really,
as long as you document that you made an attempt to collect it and the patient
right.
has. So that's the caveat to that. Let me just throw that in. I didn't mean to interrupt you, Guy.
No, it's absolutely true. But again, if I haven't accepted assignment of benefits, things I have not agreed to the terms of the insurance, so it puts us at less risk or anything like that if there ever was an audit in the future. Bottom line, what does all this mean? Patients care about how much it costs them. They like to know that the insurance pays something. They hope, if you went down the street to another dentist, and even if the cost out of pocket was similar, but they thought you were going to mess with their insurance, they would rather come to someone who says, yeah, we deal with medical insurance, and the cost I can afford. So the less they have to pay, the more they're going to like what they just say, say yes to what you have to say. One part about this we talk about, Rich, is, I was fee for service for many years in my practice, and I was in my dental practice, and I did it in sleep. And I remember talking to you saying, I'm doing this on all my patients. How are you getting all those referrals, Rich? What'd you tell me?
Well,
you gotta
you gotta play their game. I think that's the biggest part, because physicians, I think they resent dentists in a lot of ways because dentists never really had to play the game the way that physicians do. So when a physician refers somebody to a dentist and the dentist says, hey, we don't take your insurance, it's $3,000, we don't have any other options, that's just it. When that patient goes back to that physician and tells them that physician just goes, why, that dirty, rotten scoundrel, I'm never referring anybody to that guy again. Now contrast that with, they went to see Dr. Drake, and Dr. Drake says, well, we've got a couple of options. If we do, we can get a Gaff Exception, we go out of network, here's what we're anticipating they'll pay. We're going to get your part down to $1,200 or whatever it is, and Guy's going to go through all of this tonight and how we do that. Now that patient goes back and says, they really work with me. They helped me with my insurance, and they did this and they did that. And I think if the physicians just know that, you are going to get more referrals. I don't know any other way to say it, but it really absolutely does make a
Well, I
difference.
can say it one other way. If you don't do that, you will never get referrals. So, I mean, and you don't have to do that to treat your own patients in your office. But if you want to work with physicians, you're going to have to deal with medical insurance. It's just that simple. We can talk about how to develop a fee. And, I'll leave a slide up here for a second. I don't want to take the whole night doing this. But basically, if you could do this and make the same amount of money as you will doing other procedures you like and are profitable in your office, then most dentists we train, and we train thousands of them across the nation, they say, yeah, I'd like to do this. So all you have to do is pick a fee, a dental procedure, and let's analyze the fee, how much time it takes for you, how much time it takes for your team member, and then let's kind of back into the number you would need in your dental sleep office. So just to give you an example, and just kind of a disclaimer, two things. One, we still see a lot of questions coming in. We are getting to those. Our four-pillar beams, billing team is answering those, so keep them coming, and we'll get to them all the way at the end. We're going to go through some numbers tonight, and the numbers, none of them are numbers I absolutely use. This $1,300 wasn't a crown fee in my office. We just picked some numbers to try to make this example so you can look how to do this. Use your own numbers. You need to know your own overhead. You need to know what's right in your own practice. But as an example, if we chose if we charged rather $1,300 for a crown, and it took 2 hours of chair time and an hour of doctor time, and we had a lab bill of $300, we take the $300 off, we can have the doctor time at $1,000 here and the chair time at $500. And you could just kind of back into dental sleep by saying a lab fee's around $350. That's a reasonable fee. It could take 2.5 hours of assistant or chair time, an hour of doctor time. If you tune in November 6th, we'll talk to you about the steps of dental sleep. And I promise you can do this in under an hour of doctor time. And you just reverse the formula. You can go by chair time, or you can go by doctor time, or you can average the two, is what I did. And at the end of the day, you have a number. And I can tell you that number, when we sit down with the offices we consult with, and we actually do this really for them, we sit down, we look at their fees, and we really come up with a real number here. That number is surprisingly low compared to what people think they need to do this. It's usually is around $1,500 to $2,500, sometimes as much as $3,000, but most of the time it's in the $1,500, $2,000 range, because this does not require a lot of dentist time to do this. A team member can do this, and it can be going in the background. So, Rich, you're in network with how many? 2 or 3?
I think it's 5 now. And
Wow.
Interestingly, one of the questions we have here, Guy, is, well, what if I can't get a Gaff exception because there's an oral surgeon in my neighborhood that's in network? That is exactly what prompted me to get in network,
Right.
with Aetna in the beginning, 15 years ago when I did that, because we just couldn't get them to pay us or give us a Gaff exception. Right. So, it's I would say it's less of a lengthy process now than it was, 5 years ago. If you work with a reputable billing company, again, they can help you do this. They're going to charge you something, but time is money. And the hard part is now negotiating a fee when you want to do this. So it's one part of the country is completely separate and different from another part of the country. But you got to remember that you're entering a contract. And when you do that, you're going to agree to a fee. You're going to agree if you provide them with A, B, C, D, E, then they're going to allow this amount. And now you can do a verification of benefits in DS3 by clicking a button. And now we know what the patient's out of pocket is, because a lot of what I think you're going to try to get through tonight, Guy, to these people, is that if you can do an out-of-network model where you can tell the patient what their part is going to be, right, and you can still not be at too much risk yourself,
right,
then now we have a win-win. Now the patient accepts treatment and we do this. The in-network model is just supposed to make that a little bit easier. So I would probably tell you, stay out of network as long as you're getting paid and as long as you have a system that works. But when it's not working anymore, then, you go over to the dark side, I guess, like I have.
Well, and you don't have to do it for all carriers. providers rather. So I mean, so maybe you have one that you might need to get in network with, but you left out. You said that very well. In network, you know the amount. I think that's the key. But one thing that I want to make clear is the amount is almost always less than the out of network allowable amount, if they have both in and out of network benefits. And most, depending on what region you're in, most places do. So let me say it again: the out of network, the amount they allow is almost always more. Sometimes thousands.
It can be twice as much more.
It can be 4 times as much. I mean, so it can be a whole lot more. So you do a few cases, you get paid a lot more for. It can certainly make up for doing dozens of ones that maybe you're getting paid less. So you got to work all that out. And again, I think the smartest thing, one of the smartest things that Rich said tonight, which I'm sure he'll say a lot of other smart things, is stick with the out of network until it's not working. And then you might consider the in network, because once you get in network, it's hard to go back. Out of network, the biggest hurdle is you don't know how much they will allow, and you never will. You can't do it. You can say you predict it, but they're not going to tell us how much they allow. And everything we're going to talk about going forward is how we deal with that in a system to make it predictable for the patient with a little bit of risk going on us. And we can apply for gap coverage if need be, and we'll talk about what that is in just a moment. And there's all kinds of ways to get this done. You can bill for every appointment. You can bill for a fixed amount, flexible amounts. To make it simple, I don't know, Rich, I haven't asked just lately, but in our office, we just bill one code, the E0486, and that includes something. 3 months, 6 months, it's up to us. And Medicare's got its own rules. If we get around to talking about that, we will. But for commercial insurances, Plan A and Plan B, we're going to give them is all included in this fee we're going to go through. If we do a cone beam, that's going to be included too in this overall fee. Do you break it down for appointments? No,
nope.
Still doing all one code.
They'll do it just like that. I'm so glad to see you've come around to doing it my way now, guy.
Years ago, I tried to bill all the appointments, and you know what?
Sometimes you got paid for a little bit here and there, but it almost seems like it's not worth the effort, doesn't it?
It didn't. I mean, I'd be doing it if it was worth the effort in my practice. And again, I think we started out tonight by saying this is different than the last time we did this. And you know what? It'll probably be different than the next time, because it's a moving target. Things are changing. That's yet another reason to use a third-party biller to help you with this, because they're always ahead of the curve, and we find these things out as we go along the way. So if you want more information, again, you can type in consultation, and we'll be happy to sit down with you at any time. All right. Whether you do it in or out of network, the first thing we want to do is know what a patient's benefits are. And I want to know this prior to the patient sitting in my chair and saying, how much is it? I'm excited to get this going. This looks great. I want to do it. I like to know that, be prepared to answer that question. Now, you can make a phone call, and you can get on the phone and get on hold, and you can gather this information. Some of your third-party billers will charge you to do this. But as DS3, you can click a button, and we can get this information with the click of a button for over, 4,500 payers, I think it is.
A bunch.
And this gives us both in and out of network benefits. It gives us how much deductibles are remaining, both in and out of network, what the co-pays are, so 70, 30, 20, 80, whatever that is, and how much the deductibles left in both. So you start with that information. So with that information, we're going to go walk through a flow sheet on what we're going to tell the patient. And in order to do that, we need to know how much I want for, an ideal case. That's the desired amount. We need to know how much we want for the Plan B. So that's kind of our, minimal amount we want. And if a patient doesn't have insurance, or let's say they have an in-network only, that's one of the reasons, Rich, you said you applied, you started to get people that said, I can't come to you because I only have in-network, and so there's nothing we can do here. There are times you'll be dead in the water. I guess that was happening more, and maybe you have to pivot at that point. But if someone comes into my office and they have a really high deductible, or they have a only in-network benefits, I want to be able to offer them a benefit to come to me, and I can lower what I need because of the fact that I don't have to do all this billing.
Right.
It's less work. There's the caveat with that, what I'll explain in just a minute. And then we need to estimate the insurance allowable. And we're going to look at best case and worst case scenario. Okay, and then we get that information. I know it looks confusing. Again, if any of this doesn't sink in, just type in consultation and we'll be happy to go over it with you afterwards. So I want everybody to memorize this right now.
There'll be a test on it at the end.
Yeah.
You won't get your CE until you can answer it.
Can you tell I was in engineering before I went to dental school? I mean, that's why we help develop DS3. I love this stuff. I could do this all day long, but I promise to make this a lot more clear to you. We're going to walk right through it. We're going to break it down. So don't try to get caught up. Here's what we just established a few minutes ago on the previous slide. We're going to do our instant eligibility check. And I want to concentrate on these first two boxes. One is if the remaining deductible is greater than or equal to my cash fee. The other is if the remaining deductible is less. This is all for out of network, by the way, less than our cash fee. Okay, can we get that kind of, and let's kind of ignore the rest of it down there for now. So I'm going to walk you through a scenario on each leg of this. I think it'll make more sense, hopefully, because it is a system, but this works very well if used appropriately. So in the scenarios, I'm going to go through on this patient tonight. We'll have two samples. The first one is, let's say I have my option A, and that's my, Rich has some really great milled devices now. Are you using some of those? ProSomnus does a great one. Dynaflex is doing some now. I mean, these things are
almost all of them now.
Right. But they're more costly, aren't they?
Yep.
They cost more to make. They cost more, but I can warranty those a little longer. So I might put those in the, plan A in my practice. So we might throw in some follow-up sleep testing that we cover in our office or something. Okay. Now maybe I have my plan B. I can be happy to make $1,500 with doing an EMA or sometimes a TAP or some of these other devices where I'm not paying as much as those milled devices. And so that's the plan B. Again, I'm just using two scenarios. Let's say that we're happy with the 1,500, and if someone comes in and we want to just give them any device they want and really give them basically our plan A treatment, we're going to do 2,500 instead of 3,000 because we don't have to file the insurance. We don't have to bill the insurance company. But let me tell you this: if someone's a cash fee, that's what we do. We don't mess with any of it. We tell them we're not going to file it. We're not going to, if you want to copy your chart, we'll give it to you. Don't ask us to fill out the form. Don't ask us for anything.
Don't ask us to chase down a letter of medical necessity from your doctor or any of that.
Is that worth $500 in this scenario? I mean, you don't have to pay your third-party bill or anything. I mean, I think that's so. What I used to do is do the cash fee, but then still bill it, and I decided a mistake because I'm still doing all the work that you would be doing. So in this scenario, we'll say the cash fee is $500 off of the desired because of that. And we're going to say that, here's what you're going to have to estimate. And this is it's very much where your insurance billing company will help you. They will be able to tell you, you know what, on average in your area for what you're billing, because how much you bill can affect what's allowed. If you only bill 2,000, they're never going to allow 3,000. There's a trick right there. They're never going to allow more than you bill. So I think hopefully you all get that off the bat. But, so
I don't even think you need to say that again, Guy.
You think everybody will get that one?
Yeah.
Well, but anyway, it does affect it. So they can work with you and say, what are you billing? Why don't you plug into this formula 3,000 in this scenario that's a reasonable amount that they may allow. What's the worst case scenario of what they're going to allow? I plugged in the Medicare allowable here, Rich, in our area, because it's seldom that they don't allow at least the Medicare allowable amount. So we click the button, right? And instant eligibility check says they have $2,600 left on their deductible and they have 70/30 coverage. Okay, have I lost anybody here? I hope not. Rich is going along because it's not exactly the way he does it in his office. So we even have a spreadsheet that we put together that we can share with you if you want to type in consultation that does those calculations for you. But it's fairly simple. In this case, it says use the cash fee. It prompts you to do that because 2,600 is over the 2,500 allowable. So we did the instant eligibility check. The deductible is $2,600. Can you see it on your screen okay, Rich?
Yes.
Okay, great. So this is cash fee because the deductible is greater than the $2,500 cash fee that we established. We tell the patient it's $2,500. You can pay that in one payment, care credit, whatever you do, credit cards in your office, however you would collect the other money. And if they say yes to treatment, we're done. We're down here to scheduling. Okay. And what's surprising to me, and I live in Florida in a somewhat affluent area, and I know this won't work in every area, but I promise you in some areas, someone will go right down the side. If you ask enough people that, and you can't just assume they won't pay it. You say, this is it. You really have a high deductible. Because of that, we're going to discount our fee for you. And if they say yes, we're done. If they say no.
I think a lot of that too, Guy, is in how you present it. I mean, we could talk for an hour about that too. So if I don't make excuses and I don't do this and I don't do that, and I used to, people say, how much for that little piece of plastic? And I step back and I say, well, that little piece of plastic doesn't keep you alive.
Yeah, right. And
so again, act like you do this all the time. We like to say fake it till you make it, but you're absolutely right, Guy. You'll be surprised if you just do that, how many people just say yes.
Yeah, but you know what you're saying there, Rich? This was part of our presentation on Friday. People don't buy what you sell. They buy what you believe. And I had that slide up Friday. And if I believe that this is worth $2,500 to, and most patients can afford $2,500 to save their life. I don't care if you're Eastern Kentucky where I grew up, or you're Anna Maria Island, Florida, where I live. Most people can afford it. And if I can look them in the eye and go, I'm sorry your deductible so high. We're going to take great care of you. Here's what we're going to do. This is going to cover you for 2 years, whatever your package includes. And I look in the eye and say, you really need to consider doing this. And I believe it. We're going to get a lot of people to go right down this left side because I believe it's a valuable service. It's worth the money. And I can look at them. And I'm not saying these are my fees exactly, but they're not that far off. So, understand I can look at someone in the eye and say that that's a valuable.
So what happens if they say, well, I really can't afford that?
Then we go here. See, this is fun. We go, and you go over to gap coverage. So now that instant eligibility check that you did, and when we run that, we write them both down in DS3. We have a place in our ledger notes where we make those. My team does that before I ever see the patient, so I can glance at that and know where I'm going to go on here. And let's assume they had a $2,600 out-of-network deductible left to make, but their in-network deductible is only $500 left to meet. And they had even if they didn't have out-of-network benefits, and we've maybe know that we've tried gap coverage before. If you haven't, you try gap coverage. You click a button in DS3. You tell the DS3 billing company you're working with, 4-pillar billing, whoever it is, hey, I want you to try for gap coverage. Now it can take a few days to 3 or 4 weeks. And what gap coverage is, for those of you who don't know, is they go to the insurance company and say, look, this dentist wants to provide this coverage, and if there's no other providers in the area, there's a gap in the patient's coverage, so we want him to get the in-network for this one case. And it used to work always because there were no providers around. More and more, there's more and more providers, and as you get providers in your area, this won't work. But even here in Florida, other than I think it's Blue Cross Blue Shield, we get gap coverage quite often. So again, if their in-network deductible is lower, and then we can ask for gap coverage. We'll have to wait. You can't get them scheduled until you know whether you get that or not. It may take 2 or 3 weeks. It's taken 6 weeks in some cases. We get the gap coverage. We discuss that. If they agree to it, we go ahead and deliver the device. Have I lost you there, Rich, at all? With me?
No, I'm with you, but that is a little bit confusing. And if you guys didn't get that again, just type in consult. There's no obligation. We really, Guy and I, do this because we like to help dentists succeed at this.
Right. The big difference, what I used to do is I did gap coverage if they had low deductible to start with. And you know what will happen here is you'll miss out on just making your life easier and just getting the patient to say yes to treatment. And it's actually a better service for the patient, because going with gap coverage slows things down, which may make the patient not end up doing treatment down the road. So if I can get the patient treated today, because I don't have to go through gap coverage and they're able and willing to pay for it if they have high deductibles, then let's do it. It's not like we're doing a disservice to patient. I will argue we were doing a disservice by doing gap coverage first and slowing down the treatment. What happens is that patient has a heart attack in their sleep because we're sitting around waiting on gap coverage or so forth. So if for some reason the gap coverage doesn't come back and make it a reasonable amount for the patient, we can go with our back pocket. We can pull out the provisional and say, you know what, let's try this out. It's however many hundreds of dollars. It's not in the thousands, and whatever that includes. So we have a third option. I mean, so we've got to go through a lot of things before we get to stop treatment here with the patient. We have 3 options to go through, even if this high deductible patient walks through the door. Okay. So,
and I like the idea too, guys. So just so that everybody knows, this is the option A and the option B that we just did. You didn't have that up there, guys. So let me make sure everybody understands. When we talked about that, the left side of your screen is option A, the right side is option B, and then the provisional part is the MyTap that we keep in our back pocket. And the little carrot that we always dangle out there too, Guy, is, we charge $700-800 to do this. Well, I don't even know what we charge, but it's, and like you said, it's not too much. And we tell them, look, if this really worked for you and you decide you want a more permanent device, we'll credit half of that amount towards your out of pocket when we do this other part too, so that they don't feel like they're, And I think you mentioned that before, but I want to say it again.
Yeah, I don't think we don't do quite half, but whatever the numbers you have to figure out what makes sense.
Well, it doesn't matter, even if it's anything at all. It helps them feel like you're trying to meet them halfway. I think is reasonable.
Absolutely, we credit a certain amount towards option A or B if we go with the MyTap, provisional option along the way. So okay, that one's high deductible. We try to get gap coverage. It doesn't work. Then we end up the MyTap if we have to. Now this happens just as much in my office though. Someone comes in. Again, we're not messing with these numbers. These are the same that we had on the last scenario. 3,000 is what we'd love to have. 1,500s are option B. Cash fees 2,500. And these are the estimated allowables. 3,000 is what we think the insurance will allow. 1,070 is the worst case scenario. Now this one's doing better. They have $500 deductible. Remain out of network, and then 70/30. Now I'll flip it over here. You can use our fancy MOP calculator to get to these numbers, 1250, 1101, or MOOP calculator as we call it, because I've pronounced, got to get both O's into that pronunciation. Maximum out of pockets, what we made up to call that. And how does that work? Well, they have a $3,000 deductible. You subtract out $500. Okay, then you times 2,500 times their 30%. That's $750. You add the 500, $1,250. That's if $3,000 is the allowable amount. That's how much the patient's portion should be. If they only allow 1,070, you just do the same math. You take the 1,070 minus 500, and you do the math, and it comes out to 1101. I think is what it came out to there, right? So how does this work? And
guys, back up one slide there. There was a question. Somebody really wanted to see that spreadsheet again.
Which one? The spreadsheet?
Go back one slide, I think. You had it there for a second.
That one?
Maybe it's...
Well, if they want to, we can get to it. I want to make sure we get done here with this before we get to it. So essentially, to calculate the math on that, you take out the deductible, and then you times the percentage, and that's where you get up. But this is a scenario, and you can do the math. I'm sure your insurance companies can help if you don't understand how to do that. But what does this mean? At the end of the day, we have a worst case scenario, a best case scenario, and then a worst case scenario of how much the patient would have to be if that's allowed. And now understand, if the patient had a $1,000 deductible, there might be a bigger discrepancy between these two. So we did the instant eligibility, had a $500 deductible. We calculate the maximum out of pocket if 3,000 is allowed, and the maximum out of pocket if 1,070 is allowed. And this is what we came up with if the math is correct. And again, the numbers aren't important. We tell the patient, look, we've calculated this. This is what we believe your allowable is going to be. And we want to collect that. And then we're going to bill this to your insurance. The checks are going to go to you. Whatever check you get that comes to you, you're going to deposit and you're going to bring back to us. Okay. Now, again, I didn't accept assignment of benefits. So therefore, I'm not obligating myself to the insurance criteria of what we have to do. If they say yes, I'll go ahead and schedule them. They know that their amount out of pocket is $1,250. We don't want to deliver the device until we do the pre-authorization, because most of the time the insurance companies require pre-authorization. That may take several weeks, but you can go ahead and get started as long as you've, got your financial agreements. You never want to deliver the device until the pre-authorization is completed. Once the pre-authorization completed, we can deliver it, and that's the day we bill the device to the insurance company. When the checks, we keep telling the patient we're going to bill this out at whatever amount we told them we're going to bill it out, which is more than $3,000. They're going to keep getting statements for $3,000 minus what they paid us until they get their insurance check, and until they provide us with the EOB from the insurance check, and then they bring that in or mail it in along with the check for the desired amount. If they allowed a lot more than what we estimated, that's good news. There are cases where we actually owe the patient money back if they paid the full amount or something like that, and that's fine. I don't want to ever collect more than I bill, but most of the time that's not the scenario. The only difference here would be if the patient says, no, that's too much, we can go with option B, which is a little different. It may have a little different devices in it. It may have a little different follow through. And again, in this scenario, the discrepancy is not that much between. I probably should have picked one a little bit where these were a little bit more. But assuming that they say no to both of them, then we can still try the gap coverage or go with the provisional option as we've had. So, what we've made it happen here, Rich, is I tell the patient a specific amount. If they say, I can afford that, then we go forward with the treatment. If they can't, we have other options, which are different options. We're taking the risk on that. Occasionally, we're going to be wrong. Occasionally, something might not get paid at all. Occasionally, the patient may keep that insurance check. And so you have to make sure your fees are accommodating of that. So I know that's a pretty screen, but it can be a slight bit confusing. Again, we'll be happy to discuss it more with you if you want to schedule a consultation. But by doing this, what I've done differently than what I did before is I have allowed the check to go to the patient. The patient provides me with that because they keep getting the bill, which is more. So they want that to go away, so they're happy to provide the EOB and pay the difference. And I've given them an amount that I've set more fixed, at least by my standards, because I'm taking the risk. And I didn't do that as well in the past, to where we would say we think it's going to be this amount, but if it's not, you owe the full amount. If you're not willing to take that risk, and you tell the patient, well, I think they're going to pay this, but ultimately they may not, and if they don't, you owe me the full amount. That doesn't help a whole lot with their budgeting and them wanting to say yes to treatment.
Yeah, again, and it's the same thing with what we talked about with the in-network guy. We're just trying to make this to where I think patients really see through most of you providers, and they understand how confident you are in what you do. And if you're confident, just like you said, Guy, they're more willing to buy into not what you're selling, but into your confidence, or what how did you put that before? Into what you believe.
They'll do what you believe.
Yeah. And there just isn't a lot of difference here in that particular instance. So remember that we're trying to make this a win-win, where the patient and the reason I think, Guy, the reason I take some of that risk is because I want to treat patients. That's why I go to work. I still want to make a living. I want to pay all my bills and have some at the end. But the more of this you do, the more you work with your third-party biller, the more that you'll know what they're going to pay, and the less risk you take, because you've worked with this particular insurance company before on multiple times. So, it's a little bit more risk at the front end, but as you do this more and more and more and more, we've done this so many times now, Guy, we know what these people are going to pay. We're very, very confident in what that's going to be. And then we still bill them, just like you said, because they have to bring in the EOB and show us, because when we don't accept assignment of benefits, I don't know that we've ever gotten an EOB. If we did, it was probably by mistake. They sent it to us instead of the patient, but the patient will then bring that in, and then they can show you what they paid so that they can actually pay less.
Right. And here's where we note it in DS3. They'd run that instant eligibility check. They say there's a $500 deductible, 70/30. And then they say, worst case scenario, we're going to, the MOOP's 1,100. That's for plan B. $1,250 for plan A. Again, next time I probably should make a little more discrepancy between those. I think some key points to remember, and we'll get to all these questions, are you've got to let the patient know, look, we're accepting this amount. We're taking the risk. We're billing it at this amount. They need to know what your billable amount is, because if it's more, they just need to know, because they don't want to get freaked out when they get the EOB back if it's more than what they thought it was. And you tell the patient, we're going to accept whatever your insurance allows. And they like that, you know, and we do. That's exactly what we do, accept what they allow. If they allowed less than 1,070, well, then I'm the one that, you know, takes that on the chin, not them. And so they understand that. And so what we want to make sure is that when they get that statement, that they bring the EOB back to us, because the insurance companies won't give it to us readily. They won't even give it to your third-party billers oftentimes, so we don't know what they allowed. So the only way we wipe their ledger clean is when they provide us with that EOB. We write off the difference between what the insurance allowed and what we billed. Nothing wrong with doing that. No one expects you to collect what they don't allow. And then we balance up the ledger based on where we told them their maximum out of pocket was. I think signing a financial agreement, because, you know, as we talk about this, I know some of you might be looking at that, wow, it's a lot of information, it's confusing. It's confusing to understand how we do that, but the patient shouldn't be confused. They know at the end of the day, here's an amount that's going to be the most that they have out of the pocket, and they need to sign something understanding that those checks that go to them are the ones that are actually going to come back to us after they deposit them. You need to make sure you have notes in your ledger so you know what you discussed. And they have to also understand that we are doing all this and with the desire and understand that we're going to get insurance payments for our patients. So why are we spending an hour on a Tuesday night talking about this? It's confusing. It's difficult. But if you'll go back and you'll get the help of a third-party biller that understands what we just talked about, you can have less money out of your patients' pockets while you're helping save their lives and make their lives better. And if you can do that, you're going to help more patients. And what we've done by doing this in our office now, a little different than we did before, we're lowering the patients out of pocket. We are making it predictable so they know when they leave the most is going to cost them out of their pocket. And we're at not as much risk because the checks are going to the patients and we're treating more patients. And that's really why Rich and I are spending our evening with you, because we care about getting more dentists involved in doing just this. If you're not using DS3 or a third-party biller, we really encourage you to consider so. 4-pillar billing, if you're getting some great answers to your questions, they're answering most of them as we go through. I know Rich is answering some. In DS3, it is really, really simple. There's a button you click for the instant eligibility. Once you have that, you can document things in DS3. You hit a button to submit it to 4-pillar billing. They process it, and then it comes right back into your software. So there's not any, a lot of the paperwork that has to be faxed and so forth is all digitized and made really easy for you in DS3. So if you'd like to learn about that, just type in consultation. Or if you want some of these slides or want some clarification, we'd be happy to spend some time and make sure that you really understand what we went through today. Next time will be a little easier, I think. Dental billing is, I would say, out-of-network billing is the most
one of the more complicated things that we do. Absolutely. Yeah, it really is. You know, as dentists, we get the treatment steps. You know, once we get that, we can do that. So, and we had quite a few people type in consultation guy. I want to make sure everybody understands that, you know, we do this to help dentists, you know, and we help more patients because of what you and I have done over the last decade, Guy. There are a lot of patients being treated now, you know, that wouldn't have been otherwise. So sure, we want you to be a DS3 member, but we also help you do this. So, you know, we're happy to share some of this with you if you type consultation. This entire presentation is on our YouTube channel, you know, in a day or two. You can see it there as well. And it's all good, Guy. You did a good job of explaining that.
Yeah, and at DS3, we help from everything from billing to which device to use. A lot of these webinars, we focus on treatment steps to managing side effects. So do we know everything? No, but we know more than about anybody out there. I can guarantee you that. We help thousands of offices succeed at dental sleep. We have a whole team. We actually had a job fair today to hire more team members because we're growing so much. And we're here to help you. Every day we go into the office, and our job is to help dentists with whatever hurdles they have that are preventing them from succeeding at dental sleep. And if you want to know more, type in consultation. If you want something for free, I mean, I think we're pretty good about doing things for free. This is free. You get that CE credit for it. Just sign up for this magazine. We put this out every other month. DentalSleepInsider.com is where you go. You can look at all the back issues. There's videos, there's articles, and they're all heavy on dental sleep implementation. So costs you nothing but the time it takes to sign up. Rich, I'm excited about the advanced course. I'm bummed I can't be there. It's going to be a great day with you and Keith and Martin Fowler.
Yeah, and we only have a couple spots left. We will be doing more of those in the future. You know, if you can't make that one, again, you know, I wouldn't recommend that course if you've only made 3 dental devices, but if you've made 30 or more, then probably, you know, anybody will get something out of it. But we're going to be talking about some stuff that you will have wanted to at least have done a few of these.
Yeah, and if you've done enough to know that this isn't the easiest thing on all patients. So let me say that again. Most patients, this is really a fun and enjoyable, easy thing to do, but there's some challenging patients. And so those ones in between that are a little more challenging, this will help you with those challenging patients. And I don't think there's anybody better in the country than Rich Drake and Keith Orton to sit down and you know, bring your questions and hurdles to. So look at this, we're on time. Look at this, Rich. If you want more information, there's how you can get a hold of us. I hope this has been beneficial. I always kind of cringe when we do medical billing because it's almost like talking about religion or something. There's so many different beliefs and ways of doing this. I want to timestamp this. This is October, what, 9th is it today? 8th, 9th, yes. Whatever today. October 9th, 2018. You know, and you hear this in 2 years from now, I guarantee you we'll be doing something different than this because it always changes. We're always trying to pivot and make things easier and better for our own practices and our patients, as well as you. So if you want no more than, again, contact us. If you want to come to one of the courses, you can always register online, but if you type in course, that'll secure your $200 on a 2-day hands-on. I think I'm going, where am I going? I'm going to St. Louis this weekend, Rochester the weekend after. We got one in Cleveland the weekend after that. We're getting our 2019 schedule be published here shortly, so look for those courses. Any questions we didn't get to here, Rich? Man, you all are on fire getting these things done here.
Yeah, that's our wonderful team that we have working on this. So
I see check marks through here. Yep, I see most of them. Is there anything not answered on here, Rich? You've been managing this.
Well, you know, you got to remember too, when you write off stuff, you have to be careful. Okay, so, you know, if it's Medicare patients, we always have the Medicare patient sign the ABN. That's the Advanced Beneficiary Notice. And if you think about this, guy, for me as a Medicare patient, you know, it's designed to protect me so that I don't come to you and I don't think I'm going to owe you anything but $100, and then you treat me and then you tell me I owe you $100,000.
Wow.
I mean, it makes sense, you know, when you think about it. So as long as you have the patient sign the ABN and you are out of network, you know, you do not accept assignment, then you're allowed to balance bill the patient, and then you know what they're going to pay, and then you collect the part that you're supposed to collect, or at least make an attempt to do it.
Yeah, and I think one of the questions on here, actually, let's let my good friend Steve, hope you're doing well, Steve, asked this. Everything we've talked about, I want this, hopefully everybody's on here still, has been for commercial insurance. We did not have time to get into Medicare billing tonight. The subject was out-of-network billing. Medicare is not really covered under this. It's all commercial insurance, and so we really didn't get to the point of Medicare. So please tune in another day for how we bill our Medicare patients. This has been for commercial out-of-network billing and not Medicare, because we haven't even really addressed that. We have a different model. In some ways, it's much easier than commercial, because we oftentimes know what they will allow. But in some ways, there's a few other hurdles. So again, this is all about commercial insurance tonight.
Yeah, but the other part of that too, to answer Steve's question, is, you know, and it goes back to the ethics of fees and all of that. You know, we are obligated to try to collect the patient's copay, their co-insurance. You know, we are obligated as a healthcare provider to try to do that. I think if you and I were running an insurance company, Guy, we would certainly want, you know, to have our doctors, you know, try to collect that. So we're not trying to tell you, you know, just blatantly write off all of this stuff and do
Absolutely.
that. You do have to make, you know, a legitimate effort. And again, you document how you do all of that stuff. And again, the next time we do a medical billing, we'll make sure that we include Medicare. Guy had that in here, and we just didn't have time tonight. You know, would have added another 30 minutes. But again, document. The advanced beneficiary notice is something that you'll want to become very familiar with. If you don't know that, please type in consult. We'll have somebody go over that with you.
Yeah. That's right. So I think that I looked through, I didn't see any other ones that we didn't address that I know of. So, well, it's great. I mean, I really appreciate the, you know, well over, in the 3 digits here of people on here tonight. That's just exciting to see. I remember there were days where Rich we'd be happy to have 15 people on here. So it's just great questions. We really appreciate all you all taking your evening out. You can tell I'm from Kentucky, all y'all. You know, most people don't. I've been hanging around Lisa a little bit too much.
For y'all, all y'all. That's pretty much the South, Guy.
Accent for a second there, but yeah, I guess so. But glad that you took the evening. I hope it's worthwhile. And again, if there's any clarification you need, just contact us. We'll be happy to go over it with you. We're not high pressure people. We're not going to just try to talk to you about our services. We will absolutely answer your questions. Our 4-pillar billing team just we'll be right on it. So let us know and try to come to our symposium or a course where we can meet you in person. And thanks for taking the evening. And I see a lot of thanks coming through. Thank you all for your attention, and look for your CE in a few days. And I think that's it. Everybody's ready to go.
Very good, Guy. You did a great
night.
job as always putting that thing together. So thank you guys for spending the evening with us.
Good night. All right. Bye-bye.